Assalamu alaikum. Myself Isha Tariq Bhatti, MPhil Pharmaceutics from Punjab University. I'm working as a lecturer in Faculty of Pharmacy, Hajweri University. This is my second lecture of Biopharmaceutics and Pharmacokinetics, and the topic of today's discussion is Biotransformation and Renal Drug Excretion. So first of all, we will see what are the learning outcome of this lecture. So by the end of this lecture, students will be able to understand drug elimination, drug excretion, biotransformation, pathways of biotransformation, first order elimination reactions, then renal drug excretion, glomerular filtration, then active tubular secretions and tubular secretions. So first of all, we will see what is drug elimination. So drugs are removed from the body by various elimination processes. There are many processes through which the drug get eliminated from the body. So drug elimination refers to the irreversible removal of drug from the body by all routes of elimination. So drug elimination is usually divided into two major components. First is excretion and the other one is biotransformation. Biotransformation is also known as drug metabolism. So next is drug excretion. So drug excretion is the removal of intact drug. Removal of intact drug from the body is called as drug excretion. So non-volatile drugs are excreted mainly by the renal excretion, a process in which the drug passes through the kidney to the bladder and ultimately to the urine. So non-volatile drugs, they are mainly excreted by renal excretion, and the overall process is the drug passes through kidney and then to the bladder and then ultimately to the urine. Other pathways for drug excretion may include excretion of drug into bile, different body secretions like bile, sweat, milk by lactation, or other body fluids. Drugs are eliminated, or you can say excreted in the secretion, in the different body secretions in the form of bile, sweat, saliva, or milk by lactation, and other body fluids. So then comes volatile drugs. Volatile drugs such as gaseous anesthetics or drugs with high volatility are excreted via the lungs into the expired air. As you know, volatile drugs or gaseous anesthetics are taken through inhalation route through the lungs. For their expiration, or you can say for their elimination, when the expired air, so drug get eliminated through lungs into the expired air. In this form, the volatile drugs get excreted from the body. Then comes biotransformation, which is also known as drug metabolism. Biotransformation or drug metabolism is the process by which the drug is chemically converted in the body to a metabolite. In drug element, basically biotransformation is a process in which we detoxify the drug and it is converted into a metabolite, so it gets eliminated from the body. Biotransformation is usually an enzymatic process. Basically, what happens in biotransformation is that we convert our drug into the soluble form so that it gets excreted from the body easily. Then comes a few drugs may also be changed chemically to a non-enzymatic process, for example, ester hydrolysis. In case of ester, when ester hydrolysis takes place, what happens? Ester group react with water break down into H and OH group, and the H group attach with acidic portion of the ester group, and the R group, that is alkyl group, attach with OH group of the water and form an alcohol. So an acid and alcohol is obtained in the reaction. The enzymes involved in the biotransformation of drugs are located mainly in the liver. So liver is the main site of biotransformation or drug metabolism. Mainly cytochrome P450 is involved in the metabolism of drugs. Other tissues such as kidney, lungs, small intestine, and skin also contain biotransformation enzymes. So the major biotransformation reactions takes place in liver, and other organs like kidney, liver, kidney, lungs, small intestine, and skin. Biotransformation enzymes are also located there, but in very small amount. Then comes pathways of drug biotransformation. Pathways of biotransformation may be divided into two major groups. First, two major groups of reaction that are phase 1 reaction and phase 2 reaction. What happened in phase 1 reaction? Phase 1 reaction are those reactions in which the polar functional group are introduced into the molecule or unmasked by oxidation, reduction, and hydrolysis reaction. So the major reactions which take place in phase 1 reactions are oxidation, reduction, and hydrolysis reaction, or you can say that hydroxylation reaction. Um, these reactions mainly takes place in phase 1 reaction. So the drug, which is usually non-polar, so we attach a polar functional group to the drug so that it get polarized. In phase 2 reaction, what happened? After the drug get polarized, what happened in phase 2 reactions? In this reaction, in these reaction, these are those reactions in which the functional groups of the original drug or metabolite formed in phase 1 reaction are marked by conjugation reaction. Basically, what happened in phase 2 reactions, polar drug get conjugated, or you can say complex reactions take place, and the drug is converted into soluble form. Um, most phase 2 conjugates are very soluble, are very polar, resulting in rapid drug elimination from the body. So as the drug get polar, or you can say solubilized, it is easier for drug to get eliminated from the body, or you can say excreted from the body. Phase 2 reaction include mainly methylation, acetylation, and glucuronidation reactions, and there are many other conjugation reactions which take place in phase 2 reactions. So this is about pathways, and in most cases the metabolite is formed by production of the more polar groups. In most cases, metabolite which are formed by the production of more polar groups, generally the resultant metabolite is more water soluble and certainly less lipid soluble. So the resulting metabolite which are formed in biotransformation reaction, they are more soluble, more water soluble, and they are less lipid soluble. So less drug is reabsorbed from the kidney as it is more solubilized or polarized form. It is easier for it to get eliminated from the body, and for reabsorption of the drug, it should be more lipid soluble. So as it is less lipid soluble, so less drug is reabsorbed from the kidney. Then come occasionally the metabolite is less water soluble. It is very rarely that the metabolite which are formed in biotransformation reaction, they are less water soluble. So an example, some of the earlier sulfonamides are acetylated to relatively insoluble metabolites which are precipitated in the urine in the form of crystal urea. When the drug get acetylated, it is converted into insoluble metabolites, and as it is, you can say, it is not very polar, or you can say not in the solubilized form, so it is difficult for it to get eliminated or excreted from the body. So it is precipitated in the urine in the form of crystals. So next is, in most cases, the metabolites are active. Mostly the drug which is converted into its metabolites, the metabolites which are formed, they are mostly inactive form, and they are more polar. Occasionally the metabolite is also active. Very rarely that the metabolites which are formed, they are active, and they have a capability to perform their action in the body. It's very rare phenomena. The original drug may take on the role of prodrug. In that case, in which the metabolites are active, in that case the original drug may take the role of prodrug, as it get converted into more active form, or active metabolite, which in turn perform their action in the body. So for example, we consider different drugs which get converted into their metabolites. First of all, amitriptyline or non-tritylene is converted into non-tritylene, that will perform its action into the body, and then codeine into morphine, and primidone into phenobarbital. Drug metabolism can be quantitatively altered by drug interaction. This alteration can be increased by induction of enzyme activity or reduction by competitive inhibition. So drug metabolism is quantitatively altered by drug interaction. So when drug interaction take place, what happen? It will altered the drug metabolism, and this alteration may, you can say, may increase the induction of enzyme activity, or it may reduce the activity of, you can say, metabolite, or you can say the drug, and show competitive inhibition. Here are some pharmacological activity of metabolites is shown as active drug to inactive metabolites. You can say that you can see that active drug to inactive metabolites, amphetamine is converted into phenylacetin. Phenylacetin is the inactive metabolite, and phenobarbital is converted into hydroxyphenobarbital, which is an inactive metabolite. And active drug to active metabolites, say, few examples are considered over here. Phenacetin is converted into acetaminophen, which is an active NSAID, and mepridine, that and then tritylene is converted into non-tritylene, which is active metabolite. And then active drug to active metabolite with different pharmacological activity, as you can see here, is mepridine, that is an analgesic drug, is converted into non-mepridine, that is CNS stimulant. So the therapeutic activity, or you can say that the pharmacological activity of both these drugs is different. This is an analgesic, and this is a CNS stimulant drug. So a prodrug to active metabolite, say for example, in case of chlorazepate, is converted into nordiazepine and non-nordiazepam, and Ritacillin is converted into ampicillin. So active drug to reactive metabolites, for example, acetaminophen, it is converted into reactive metabolite, which are hepatotoxic, which causes hepatotoxicity, and methoxyflurane converted into reactive metabolite, which causes renal toxicity. So first order, what is first order elimination? The rate constant of elimination is the sum of first order rate constant of metabolism and first order rate constant for excretion. So as I told you earlier, that elimination is the process in which metabolism and excretion, both these processes combine to form a term that is called as elimination. So the elimination rate constant is equal to sum of elimination rate, excretion rate constant, and metabolism rate constant. So next is renal drug excretion. So the kidney represent about 0.5% of the total body weight and receive approximately 20 to 25% of the cardiac output, that is blood. And renal excretion is a major route of elimination for many drugs. And drugs that are non-volatile, water-soluble, and have a low molecular weight, or are slowly biotransformed by the liver, are eliminated by renal excretion. So what happened in renal excretion, that non-volatile drugs which are more water soluble and have low molecular weight, or they are slowly biotransformed, and slowly biotransformed by the liver, they get eliminated by renal excretion. The process by which the drug is excreted by the kidney may include any combination of the following, that is glomerular filtration, active tubular secretion, and tubular reabsorption. These are the main processes which take place in the, you can say, in the renal excretion. So I'll show you now the nephron of the kidney, a structure of nephron of kidney. First of all, it contains Bowman capsule. Bowman capsule, that is also, and you can say that here are the network of capillaries in the Bowman capsule, which is called as glomerular, where the glomerular filtration takes place. And basically the role of Bowman capsule, or you can say glomerular, is to filtration of the small molecule from the from, you can say, from blood. The small molecules get filtered into the nephron, and then comes proximal tubule, that is the first portion of the tubular section, where active secretion of weak electrolyte, especially acidic electrolytes, are secreted here, and reabsorption of water takes place in this portion. Then comes loop of Henle. This U-shaped tube is called as loop of Henle, and reabsorption of water mainly takes place in this section. Then come distal tube and distal tubule, and passive transfer of lipid soluble drugs takes place over here. Passive transformation or transfer is basically the movement of drug from high concentration to the lower concentration without the use of energy. So the major process which takes place in this section is the reabsorption of water and lipid soluble drugs, and ultimately which you can say after the reabsorption, what remains is what remain in the fluid is then collected into the collecting ducts, from where it is excreted as a urine. So this is the nephron. Now we will consider the different processes which take place in the nephron. First of all, glomerular filtration. It is the passive process by which small molecules and drugs are filtered through the glomerulus of the nephron. So this is the passive process, as I told you earlier, that the passive process is that in which the drug move from high concentration to the lower concentration without the use of energy. So then in this passive process, the small molecules and drugs are filtered through the glomerulus of the nephron into the lumen of the nephron. Then the drugs which are bound to the plasma protein are too large to be filtered at the glomerulus. So these drugs are not get filtered through the glomerulus. And the drugs such as inulin are not actively secreted or reabsorbed. They are used to measure the glomerular filtration rate, in which we estimate that how much efficiently the kidney is performing its function. So creatinine is usually used clinically to assess the glomerular filtration rate. So now we will discuss what is active tubular secretion. It is carrier mediated active transport system that require energy. So in this system, what happened is drug is moved from lower concentration to the high concentration with the use of energy. So this is carrier mediated system, and two type of active tubular secretions pathway exist in the kidney. What are they? First, one system is for weak acids and the other system is for weak bases. So active tubular secretions show computation effect. So what happened is, for example, probenecid, a weak acid, compete for the same system as penicillin, so decreasing the rate of penicillin excretion. So what happened in this case, that the rate of penicillin, the system from which the probenecid get excreted is the same as that of penicillin. So what happened is the probenecid is excreted, takes the place of penicillin, and it will reduce the excretion of, or you can say decrease the rate of penicillin excretion. So what is tubular reabsorption? It is the process, it is a passive process that follows Fick's law of diffusion. What is Fick's law of diffusion? I will tell you later. Lipid-soluble drugs are reabsorbed from the lumen of the nephron back into the systemic circulation, and this is the equation for Fick's law of diffusion, that is dq divided by dt, that is rate of diffusion, is equal to dak, that is d is the diffusion, that is the you can say diffusion coefficient, a is the you can say surface area, k is the partition coefficient, and h is the thickness of the layer through which the you can say this diffusion takes place, thickness of the film, or you can say thickness of the layer of any membrane. And then C2 minus C1. C2 is the concentration of drug, at one phase, you can say that in the lumen, or C1 is the concentration in the plasma. So this is the Fick's law of diffusion. Now for weak electrolyte drug, urine pH affect the ratio of non-ionized to ionized drug. If the drug exit primarily in the non-ionized or lipid-soluble form, then it is reabsorbed from the lumen of the nephron. If the drug is in the you can say lipid-soluble form, so it get a you can say lipid-soluble form or non-ionized form, it get reabsorbed from the lumen of the kidney. Next is, if the drug exits primarily in the ionized or water soluble form, then it is excreted more easily in the form of urine. So the soluble drug or water soluble drug or ionized drug get excreted more easily from the urine. And there is one more point which I want to discuss over here, that if the urine is acidic, it will reabsorb the acidic drugs, and it will promote the excretion of basic drugs. And in case of basic urine, basic drugs get reabsorbed, and it will promote the excretion of acidic drugs. So this is the point which I want to discuss here. And depending on the pKa of the drug, alteration of the urine pH alters the ratio of ionized to non-ionized drug ratio and affects the rate of drug excretion. So pH is very important factor, as I told you that acidic urine promote the excretion of basic drugs, and basic urine promote the excretion of acidic drug. So pH is a very stimulating factor, or you can say very much important factor which affect the rate of drug excretion. For example, alkalinization of the urine by the administration of sodium bicarbonate increases the excretion of salicylate, that is weak acid. So basic urine causes the excretion of weak acids or acidic drugs. An increase in the urine flow caused by simultaneous administration of diuretic decreases the time for the drug reabsorption, and consequently more drug is excreted. So what happened when we take diuretic? Diuretic promote the excretion of drugs. So they get very less time for reabsorption. Then comes renal clearance. Renal clearance may be considered as the ratio of the sum of glomerular filtration and active secretion rate less the reabsorption rate divided by the plasma drug concentration. So this is the equation for renal clearance, that is clearance renal filtration rate minus secretion rate minus reabsorption rate divided by concentration CP, that is concentration in plasma. So this is about the today's lecture. We have discussed in this lecture drug elimination, then drug excretion, then biotransformation, pathways of biotransformation, that is phase 1 and phase 2 reactions, and first order elimination, that is the sum of excretion rate constant and metabolism rate constant, and then renal drug excretion, in which we have discussed different processes like glomerular filtration, active tubular secretions, and tubular secretions. So this is all about today's lecture. Thank you for listening, and write any question and if you have any question pertaining to this lecture, you can ask me on Google Classroom discussion board, and the class code for Google Classroom is mentioned on the last slide. So you can join my Google Classroom, and you can ask me any questions. So thank you so much.